Here we go, off and running, Chapter 15 or Chapter 16, respectively, Respiratory Emergencies. So we have a bunch of structures, we have a bunch of tubes. Those tubes' main goal is to move gas from the outside to the inside when we talk respiration. We have the nasopharynx. It's going to be a spot where we can put our NPA. As far as adults go, the nasopharynx, not a huge source of obstruction for an airway. Bleeding can cause some airway compromise, but adults, when we have a plugged up nose and it's not working so good, you know, it's winter time and it's Massachusetts, so everybody's sick. We switch to breathing through our mouths in the oropharynx. One of the times that we do kind of get a little concerned with the nasopharynx becoming a complete airway obstruction is with children. Children are wired a little bit differently than us. Children, especially very young kids, are what are known as obligate nose breathers or obligate nasal breathers. Kids, when they first come out all fresh and new, noses are for breathing and mouths are for eating, and that's the way it works. An airway obstruction could be caused by a complete blockage of a kid's nasopharynx. Generally speaking, we can get them to breathe through their mouth and it doesn't cause all sorts of problems, but just keep that in mind. Respiratory distress can be sort of anatomic when we talk about kids and airway positioning. In our oropharynx, moving on down the road, we have one major source of obstruction and one very effective tool to fix it. What might that be? Big muscle hangs in the middle of your face, takes up most of the room inside your oropharynx.
Tongue?
The tongue, yes. When our patient is altered or unresponsive, the tongue is a large source of upper airway obstruction with our patients who have an altered mental status. We use an OPA to correct this. It'll actually scoop and pull the tongue forward and flatten it down so that that snoring respirations that we're looking for actually goes away. One of the other things we'll do a lot with the oropharynx is if we hear any gurgling or any bubbling or see any fluid, we'll use suction. We're going to suction our patients for how long? No longer than how many seconds?
Is it 15 seconds?
It is 15 seconds. We introduce that suction catheter into our patient's oropharynx. We suction on the way out, and we clear out all of that fluid, and hopefully the airway stays clear from there. Moving on down just a little bit further, the third bit of information on our screen there is the epiglottis. Somebody out there tell me, what is the job of the epiglottis?
It keeps food and like liquids from getting into the lungs.
Yeah, it's a stop valve. Its job is to keep food and liquids going down into the esophagus and nothing but gas going down into our trachea and down into our lungs. Most of the gas that we bring in is actually filtered, warmed, and humidified in our nasopharynx. One of the big important structures we see are those ridges that you'll see on the picture here. Those are called turbinates. Those turbinates' job is to make airflow, well, turbulent. And in doing that, it tumbles out all of the particulate and gets everything sort of moved around and in contact with those mucosal membranes, so it gets warmed up and humidified, because our lungs are also lined with mucosal membranes. Our trachea is also lined with mucosal membranes. It doesn't like to have the drying nature of just the gas around us introduced down in there. As we move on further down the road from the epiglottis, we get to the larynx, where the vocal cords are, and we have worked our way into the trachea from there. When we get to the trachea, we can skip all of this because I did it without the slides. We have reached the lower airway. Once we get past that epiglottis, we are down into the trachea and we are in the structures of our lower airway. The trachea is these cartilaginous rings. They're about 3/4 of the way around a circle, and on the back they are lined with smooth muscle. The trachea points superior and anterior in your patient's chest, so down and forward. And these cartilaginous rings are very, very important as far as structural integrity goes. Without those rings, your trachea would just be sort of a floppy tube that didn't have any structure, didn't have any support, and it would be very easy for it to get closed off. Now think children again, because as we grow, those rings get a little bit more rigid and get a little bit more structural, and adults' airways stay open much better than children's do. Children's airways, since those rings haven't really started to form yet and they're not really as structurally sound, just by positioning their head incorrectly, we can cause an airway obstruction. Push their head too far forward, and we're going to pinch off the airway. Hyperextend the head too far backwards, say with a head tilt chin lift, and we're going to hyperextend the airway and pinch it in the opposite direction. What's something that we could do with the management of a pediatric airway that would probably make that a little bit better? Remember, sometimes think simple. What could we do to make a kid's airway sort of just sit nice and level?
Put a pillow under their head.
So I heard a pillow under their head, right? Is that what you said, Alyssa?
Yeah.
You're close. We don't really want to put a pillow under their head because that doesn't give us anything structural to support their head. Proportionally.
Elevate their chest.
Say that again, Lenny.
Elevate their chest.
Elevate their
So-
chest. Jessica put
Yeah.
shoulder in the chat room, and you guys are both correct. We're going to take just a little folded up towel, sheet, or a blanket or something and put it right between their shoulder blades. And it displaces their head because, proportionally speaking, if you've ever seen a little child, they got this great big whopping melon-sized head and an itty bitty teeny tiny little neck and body. So when we put something between their shoulder blades, it puts them into a nice neutral sniffing position like they're trying to smell fresh baked chocolate chip cookies. And you can almost ventilate a child with just one hand. Moving down a little bit further, we get into the trachea. From the trachea, we're into the bronchi. Those bronchi are right and left main stem respectively. The right bronchi goes into the right lung. The left bronchi goes into the left lung. And those bronchi, when they get into the lung, they continue to split and they continue to split and they get smaller and smaller and smaller and they turn into bronchioles eventually, which are also just tiny little branches of your bronchi until we get to the respiratory bronchioles and the alveoli. Now, between the out of doors and those alveoli, all we have done is ventilate. All we have done is taken something from outside and moved it to the inside. Not one thing of function has actually taken place, and we are way down deep into the lungs at this point. We are at the terminal. We are way at the end of our respiratory system. The alveoli is where all of this gas exchange actually takes place and where the oxygen and the room air that we breathe in from the out of doors actually starts to move into our bloodstream. In our respiratory system, there is somewhere in the neighborhood of about 150 milliliters of what they call dead space. Dead space is just the space taken up by gas that holds our airway structures open. So between the end of your nose and the tip of your lips and those alveoli, we have 150 milliliters of oxygen-rich gas that actually isn't doing anything to support now respiration. Respiration is that actual gas exchange, and until we get to the alveoli, not one thing of any real substance has actually taken place. As we talk about the alveoli, here's a couple of important and interesting little tidbits. They are numerous. There's about 300 million alveoli in each of your lungs. The alveolar capillary membrane, that membrane that is between the alveoli and the blood coming from the right side of the heart, is only one cell wall thick. That one cell wall makes it very easy for the oxygen to get out of those alveoli and into the bloodstream, and the carbon dioxide to get out of the bloodstream and into the alveoli so that diffusion can take place. Our blood can become oxygenated, and it will go back to the left side of the heart to be pumped out into systemic circulation. And through systemic circulation, more respiration takes place. The process we just talked about at the alveolar level is called external respiration. External respiration is the gas exchange in the alveoli from the gas from the outside actually getting down to those alveolar ducts and getting into the alveoli, and oxygen moving from the alveoli into the bloodstream. In a few minutes, we'll talk about when we get down to the cellular level. And the same process happens just in reverse. We get down to those cellular capillary beds, and that cellular capillary membrane surrounding all the cells is also very, very thin, just about one cell wall thick. And those cells are oxygen poor, and the blood is oxygen rich. Gas moves from high concentration to low, so the high concentration of oxygen in that bloodstream moves into the cells, and the cells are able to create energy, make ATP, and continue to function as cells, and we are well perfused. Some of the problems we're going to talk about as far as respiratory and ventilatory issues are going to be what happens on the body level when maybe something makes that layer between the capillaries or that layer between the alveoli and the capillary bed more than just that one cell wall thick. What do you think happens when we make that oxygen need to pass over one cell wall and something else as far as how this patient is going to now ventilate and respirate? Do you think making it more difficult to get the gas into the blood makes this process better?
No.
Okay, it doesn't. And some of the respiratory conditions that we've already talked about and some of the lung sounds that we're going to hear and discuss later on today are the actual physiologic presentation of a change in that layer, a change in the patient's ability to diffuse oxygen into the blood and out of the blood. And really, when we look at respiratory conditions, those are some of the things we're looking at. Respiratory problems come in only a couple of different flavors, and they're sort of very easy to depict and very easy to figure out. Well, if we talk about a mechanical problem with breathing, we move to this picture right here, and we can talk about problems with the mechanics of breathing. We have two lungs, we have two lobes in the left lung, we have three lobes in the right lung. The extra space that that left lung doesn't have is occupied by the heart. All of these things together are called the mediastinum. Our lungs are surrounded by two pleural linings. The visceral pleura is the part that actually is up against the lungs. And the parietal pleura is the part of our pleural lining that is actually sort of against the cell wall. And all of these pleural linings are really, really close together, but don't actually touch. There's what's called a potential space there. It's lubricating. It's made so that when we inhale and we exhale, those lungs can just expand and contract respectively, and they glide nice and easy. Because if that space turns from a potential space to an actual space, we're going to have some friction, and friction is going to generate heat and inflammation, and heat and inflammation will generate pain. Sometimes when our patient has a respiratory problem, they will complain of some significant pain when they're breathing. And a lot of the times we can sort of get into the business of figuring out, what is this pain caused by? Is it caused by a disturbance in that pleural lining? Is it caused by the fact that now with all this movement, their lungs aren't getting past each other real simple and real easy like they're supposed to? The mechanics of breathing, we've gone over a couple times. We went over them in chapter 6. We went over them in the airway lecture. Inhalation, is that an active process or a passive process?
Active.
Active, how come?
Because you have to breathe to bring air in.
Yeah, all right, you have to use energy to make that happen, right? Physically, you have to contract, now you don't have to think about it, but physically you actually have to cause muscle contraction to get that gas from the outside to the inside. I contract my intercostal muscles and it expands my chest wall out. My diaphragm pulls inferior and anterior, down and forward, and I've made the space inside my chest cavity bigger. Now, all of this is a vacuum. This is a closed system. So if I have made this space bigger, I have made the pressure smaller, and in an effort for that pressure to try and equalize itself, that muscle energy, all that contraction, all that space expansion forces that gas down into my lungs, all the way down to my alveoli, and from there, gas exchange hopefully takes place. When I want to exhale all of that carbon dioxide that's been exchanged, all of those muscles just relax and go back to their resting state. And now I have made this space smaller. And in making the space smaller, I have increased pressure, and that increased pressure forces out all of that carbon dioxide rich gas, and exhalation is a passive process. Because instead of having to use any muscle energy, instead of actually having to physically accomplish any task at all, I just relax. And in relaxing, out goes the bad air. Air goes in and out, blood goes round and round, and any deviation is bad. Right now, we're going to talk about normal breathing. So we don't have any deviation. So what would you guys consider to be normal breathing? What does it look like? What does it sound like? What does it feel like?
Their lungs sound clear.
Okay, so when I listen to their chest, their lung sounds clear. I like where you started. What else? There's plenty of stuff that we've talked about already.
It should look easy to breathe, not like stressful or painful.
All right, so it should be easy, so effortless. I heard shouldn't be painful, so we shouldn't see or be told that it is discomforting or uncomfortable to breathe. I like that. What else? I see not struggling. We're going to talk about the struggle to breathe in just a couple minutes, but you're absolutely right. So we've gotten so far noiseless, effortless, and painless. I like that. Look at yourself breathe for a couple of seconds and tell me what you see.
My chest rising.
Okay, so your chest rises. We need to see that good chest wall motion. It needs to expand and contract. We need to get good movement of air because the first 150 milliliters of space, that first volume of space, doesn't do us one bit of good. All it does is hold our airway open. So if your patient is taking these itty bitty teeny tiny little shallow breaths and their quality stinks, we have inadequate breathing. But if we have that nice chest rise and fall, and it's nice and regular in rate and rhythm, and it's not too fast and it's not too slow, we have adequate ventilation. My patient is in fact moving gas appropriately. They are able to, for all intents and purposes anyway, adequately moving gas from one place to another. We have a proper rate, rhythm, and quality. We've found breathing that is noiseless, effortless, and painless. We've gone even that one step further, and we've actually taken our stethoscope out and listened to our lung sounds, and we have found normal breathing. Now let's look at the flip side of that coin. What do you think abnormal breathing looks like.
You can see that they're having trouble breathing. They're wheezing. You can hear they're wheezing.
I might hear some wheezing. Tell me what you would say, like what would you see if your patient was having trouble breathing? Because I like where your head's at, because I can't say that you're wrong, because you're right. But what would it actually physically look like?
They'd be in the tripod position, and you'd see a lot of the accessory muscles contracting while they breathe.
Yeah, remember,
Their skin would turn a different color.
we'd see changes in their skin color, temperature, and condition. Absolutely. Rosa, what would that change in skin color actually be telling you right there in front of you, looking right back at you?
Wait, what do you mean?
You see a patient who is no longer pink, warm, and dry like we want them to be. Maybe they're gray. Maybe they're starting to turn blue. What is that telling you?
That they're having a really difficult time breathing and that they need oxygen.
Yep. And it's also telling you that this patient is no longer perfusing appropriately. Jessica, you're right. Hypoxic, sure, I'll take it. But really, on just a down and dirty type level, you look at a patient whose skin is no longer pink, warm, and dry, and they're complaining of a respiratory issue, and you found a problem with rate, rhythm, or quality. You found a problem with that whole noiseless, effortless, and painless bit. You found wonky lung sounds that you don't particularly like hearing because they don't sound nice and smooth and easy. And your patient is the color of the wall, or starting to get cyanotic, which is that bluing, hopefully at this point just around their lips and maybe in their nail beds. Or maybe we're starting to see cyanosis progress up their arms and spread across their face and chest. And we have absolutely found not only abnormal breathing, we have found a problem with their perfusion, because people who are perfusing well remain pink, warm, and dry. People that are not have problems with their skin color, temperature, and condition. And if we look at this the same way we looked at some of the other things that we've talked already, the body's response to a problem with perfusion and a problem with respiration and ventilation is to speed things up. So if the heart rate starts to climb and the respiratory rate starts to climb and your patient looks crappier and crappier with every minute, we know that their perfusion is beginning to fail. We can see in our signs and symptoms and our vital signs that their body is beginning to try and compensate. But let's talk about the actual act of moving all of this gas around, because some of it takes energy. And if I speed up my respiratory rate and I have to make all of that muscle contraction start to work faster, am I fixing the problem, or am I making it worse?
You're making it worse.
Making it worse.
I am. I'm making it worse. I am actually physically, for that 1 second, that split period in time, sure, I'm getting more gas in. My heart rate is picking up and I'm moving more gas around. But sooner rather than later, that respiratory rate is going to become too much oxygen demand and too much energy demand. And when we think about these things in the vein of perfusion, if my body is demanding more oxygen and demanding more glucose and demanding more energy than it's actually able to create because I'm having a problem respirating and ventilating, am I going to compensate forever?
Not forever.
Or is this, we're on a timetable, right? This is not something that is just going to go on and on and on and on ad nauseum, right? Stick with me, folks, because you guys are actually getting it. So let's talk about some respiratory distress. And we actually, when we get to the next couple of slides, have just sort of waded our way through respiratory distress, shortness of breath, and respiratory failure, leading up to respiratory arrest. Some of the terms we're going to use here are hypoxemia. So hypo is low, ox is oxygen, emia is in the bloodstream. So hypoxemia means there is not enough oxygenated blood going round and round to support perfusion and to support adequate respiration. Sure, my patient may well be breathing a lot. They could be breathing 12 to 20 times a minute. They could have that great good chest rise and fall. But what if the room is filled with carbon monoxide instead of oxygen? I'm going to have a low amount of oxygen in my bloodstream, right? Because there's no oxygen around. Water everywhere and not a drop to drink. The room's going to be filled with gas, but it is not a gas that does anything to support my actual perfusion, to support the actual respiration, the creation of energy, and it does nothing to provide for me as a human being. So hypoxemia is going to be low oxygen in the bloodstream. Hypoxia, hypoxia, or just spoken normally as hypoxia, now we're talking decreased oxygen in the tissues. When we're having our respiratory distress and our body needs to speed up to get more gas in, it is likely we are just suffering from this. We have low oxygen in our blood. Sooner or later, if that problem's not corrected, hypoxemia is going to lead to hypoxia. Because if there's not enough oxygen in the blood, are the cells getting fed appropriately?
No.
No, they're not. Because there's not oxygen available and near to them to create that difference in gas moving from high concentration to low concentration, because the blood isn't oxygenated properly. So all of our respiratory problems are really going to follow mostly this pattern. Generally, they start out exactly the same. We have a patient who is dyspneic or having some shortness of breath. Dyspnea means difficulty breathing. So my patient's having a hard time. And that hard time starts out as they just feel a little short of breath. You know, they're not feeling so great. And then as the problem progresses, they start to have a hard time bringing enough gas in to oxygenate their blood. Their respiratory rate picks up a little bit, but their respiratory rate picking up a little bit just makes them work harder, and it makes their oxygen demand for the act of actual movement of gas in ventilation and respiration take more energy and cost more oxygen. So their shortness of breath will continue to deteriorate and we'll wind up with hypoxia. And if our patient isn't getting enough oxygen to their tissues, that hypoxic patient's condition is going to get a little bit worse and get a little bit worse until finally we go from just shortness of breath and respiratory distress to a point of respiratory failure. Now, yesterday when we talked heart failure, what was the heart not doing appropriately? What was it not actually accomplishing well enough?
It wasn't pumping the way that it should be.
Okay, so it wasn't pumping the way that it should be. It wasn't actually supporting the needs of the body in its act of being a pump. You're absolutely correct. So if we were going to talk now instead about respiratory failure instead of heart failure, what would our respiratory system be failing to do?
To move oxygen around the body, it's not, you're not able to fill, I don't know how to explain this process, but not able to, like your
Keep
blood
going, I'll interrupt if you
isn't
say.
filling.
So
Who was talking?
not able was probably about where we could have stopped, because you're absolutely correct. It's not necessarily not breathing. It's not necessarily not ventilating, but it is not able to anymore meet the needs of the body. Anytime we talk about heart failure, respiratory failure, all it means is that particular system is no longer accomplishing its task. When we have heart failure, the heart's not accomplishing its task. When we have respiratory failure, the respiratory system's not accomplishing its task. And we wind up going from shortness of breath to low oxygen in the blood to low oxygen in the tissues. And soon enough, the respiratory effort is now no longer sustainable. And our patient goes from respiratory distress to respiratory failure. And once your patient goes into respiratory failure, the next step from there is respiratory arrest. That's when they actually completely stop ventilating on their own. Your respiratory arrest patient is no longer breathing, may still have a pulse for a short amount of time, but they are no longer contracting those intercostal muscles and contracting their diaphragm and making that space and making that pressure difference and getting gas in on their own, because they've stopped doing it altogether. Respiratory distress, a patient who is just short of breath, we're going to treat that patient. Initially anyway, our treatment for anyone who complains to us of respiratory distress or some shortness of breath is just going to be to provide for them some supplemental oxygen. We're going to start out low, and then we're going to work our way up. We're going to titrate to effect. We start them out on a nasal cannula, give them some oxygen, and see if that oxygen just going in an increased percentage can fix this hypoxemia, can fix this hypoxia, and make even just little corrections to their shortness of breath. Want to know what one of those little corrections is sometimes? Think about the things that we've talked about that need to be appropriate for breathing to be normal. Rate, rhythm, quality, noiseless, effortless, painless. When we provide supplemental oxygen to a patient and that oxygen is helping them, what do we think we see changes in almost right away?
I want to say.
Their rate.
All right,
Oh,
Lenny, I heard rate. Jessica, we have in the chat color of their skin. Alyssa, where were you headed?
I am gonna agree with Lenny.
Good, because you're all right. We actually will start to see that respiratory rate begin to improve, because now the patient's body responds to an increased bit of oxygen being available to them, and that hypoxemia starts to get fixed, and that hypoxia now begins to get fixed, and we will see changes in our patient's rate, rhythm, and quality of breathing, because that little bit of extra oxygen that we've given them has actually, at least for the time being, corrected some of the issues that are happening on a cellular level. Now, does this mean that I have now fixed their emphysema or corrected their asthma? Absolutely not. But I have factually witnessed myself give them a drug, given it appropriately, and we've seen some changes in the rate, rhythm, and quality, and we've seen some changes in noiseless, effortless, and painless, and we've seen some changes to my skin color, temperature, and condition that now are telling me my patient is beginning to perfuse more appropriately and hopefully get a little bit better. If that doesn't work, I give them a little more oxygen and I turn up the flow meter on my oxygen tank. And I maybe even go all the way up to, 4 or 6 on my nasal cannula, and I give them an increased percentage of oxygen by doing that. And if that works, great. That's what's called titrating to effect. We turn up the gas until the gas is accomplishing what we're looking for. And if a nasal cannula is not going to do it, non-rebreather mask, somewhere between 10 and 15 liters per minute. We're still going to titrate that gas to effect, because the minute I give my patient some oxygen and I watch their rate, rhythm, and quality get better, I watch their skin color, temperature, condition get better, and they tell me, hey, wow, it's a lot easier for me to breathe now. Guess what? They're improving. So we can start now getting a little bit deeper into What is going on with you? How can I actually fix it? And we'll start talking about and thinking about the things that we're going to actually be able to offer them as far as treatments go. Because all of this is during the B assessment in your primary assessment. When you're assessing breathing of your patient, during your primary assessment, your ABCs, airway needs to be open, clear, and secure. If it's not all three of those things, you need to fix it. Moving down to B, once we fixed our airway problems, breathing, we need to have an adequate rate, rhythm, and quality. We need to ensure that breathing is noiseless, effortless, and painless. Now, for examination purposes and here in the classroom, everyone is going to get a non-rebreather mask at 15 liters per minute. We'll talk about why that is when you come in today, because it's probably stuff I shouldn't say on recording. But other than that, we've found a breathing problem. We've now addressed that breathing problem because it is a primary issue. We have to make sure that we're supporting our patients' ventilation, respiration, and perfusion. And then as we move on through the rest of our assessment, we do circulation, skin color, temperature, condition, carotid and radial pulses. We make our transport decision. If you found a problem during your primary assessment, is this patient well? What do you think? If I have had to find and address something in the first minute, minute and a half of meeting this patient, do you think that this patient's status is
No.
together that great?
No.
Good, because it isn't. Primary problems are the things that are actually supporting this patient as a viable human. Airway, no patient. Breathing, no patient. Circulation, no breathing, no circulation, no patient. All the rest of the stuff that we can do isn't going to amount to a hill of beans if we don't correct those primary problems. So my transport decision is just that. My transport for this patient is they're a high priority patient to the closest appropriate facility, hopefully with an ALS intercept en route, maybe, maybe not. And from there, I actually get into the nuts and bolts and working bits of this patient's respiratory status, their respiratory issues, and try and figure out, can I treat this with anything different than what I currently am? Or do I need to just begin to transport, continue to give them oxygen titrated to effect, and get them to the emergency room where they have doctors and nurses and respiratory therapists whose job it is to actually fix and manage this problem? We're talking hamburger meatball medicine here. We are just trying to keep this patient alive by identifying what their respiratory problem is and addressing the downriver problems that that's causing. Because we're not going to cure emphysema. We're not going to cure COPD. We can maybe help their asthma, but that too is a fleeting assistance because asthma comes back. So we need to figure out what this slide here is telling us. Is this a mechanical problem? Is this a brain problem? Or is this a gas problem? Because each of those three things are going to present a little bit differently. They're going to show us different things, and they're going to require different bits of intervention from us. And what do you think would be a mechanical disruption that would cause shortness of breath?
Like there was something stuck in the throat.
So I heard trauma, I heard something stuck in the throat. So we're going to skip foreign body airway here for a minute because that's problems all over the map. But trauma, if the muscles that surround our rib cage aren't working appropriately to expand our rib cage, if our diaphragm all of a sudden decides that it's going to pack up its toys and go home and it doesn't work anymore, if our rib cage isn't actually intact and able to expand out that size of our chest wall, for one reason or another, whether it's a traumatic event, whether it's a neurological problem, if those things aren't mechanically sound and working together the way that they're supposed to get gas from out there to in here, we might as well be a fish out of water, because that mechanical problem is going to be what causes our shortness of breath. Now, it doesn't matter if your patient is, run over, the rib cage is crushed by a truck and their ribs are just completely and totally smashed. Now, okay, we're probably going to have some actual physical problems with the lungs at that point, but we have a mechanical problem, and mechanical problems require mechanical fixes most of the time. So a mechanical disruption, some of the things we need to splint, some of the things we need to cover with an occlusive dressing to make sure that we can still create that pressure difference. Sometimes with a mechanical disruption that's causing shortness of breath, we actually just wind up ventilating this patient because they're no longer able to do it on their own effectively. We'll talk about the stimulation of the receptors in just a couple of minutes. That's a bit deeper of a concept, but inadequate gas exchange. All of this is dependent on those capillary membranes and either the alveoli and the cells being really close to one another and only having to travel across that one cell wall thickness. Anything that expands out or makes that diffusion process of the gas going from high concentration to low concentration is going to affect gas exchange. So if we don't have enough oxygen in the air around us, there was recently a submarine or something that sunk, and they were talking about how they had enough oxygen on board to make it to like Saturday. Well, once that available oxygen ran out, now the percentage of oxygen around us starts to decrease, and the percentage of oxygen that we're going to breathe in actually goes down. And then we become hypoxemic, and then we become hypoxic, and then we wind up having problems with actual gas exchange because there's not enough oxygen available to us. It could be a ventilatory problem. It could be a just availability of oxygen problem. It could be a perfusion problem that affects gas exchange. Now, when we talk about stimulation of receptors, inside of our body, everywhere, there are receptors that are reading the amount of carbon dioxide in our blood and the amount of oxygen in our blood. The stimulation that most of us have to breathe, as long as we're healthy people that don't have any long-standing lung issues that are chronic things, is having too much carbon dioxide in our blood. Average everyday healthy people breathe on what's called hypercarbic drive. So hyper is high, carb meaning carbon, and the suffix IC means high carbon dioxide in the blood. Our respiratory cycle as healthy individuals is actually triggered on exhalation. The first act of your respiratory cycle is to blow out all of that bad gas, all of that carbon dioxide. And then we take a breath in to get oxygen back down to those alveoli and to cause all of this gas exchange to take place. People who have things like chronic obstructive pulmonary disease, things like emphysema, things like chronic bronchitis, and anything else that you can think of that is a chronic, long-standing lung disease, or things that actually force them to have a high carbon dioxide level in their blood, can't rely on that to breathe. Because if they relied on hypercarbic drive and their blood typically held on to carbon dioxide, they would stop breathing. The pathological process that these people breathe on is called hypoxic drive. Now, we've talked about hypoxia. So what do you think hypoxic drive does? Got all these little receptors just waiting to respond to stuff. Normal people breathe on too much carbon dioxide. People with pathologic lung problems, what do you think makes them breathe? Well, let's look at the word hypoxic. What do you think hypoxic means?
Low oxygen.
Christian, you got it. Low oxygen. People that have chronic long-standing lung problems and can't rely on hypercarbic drive to breathe based on the fact that they don't have enough oxygen in their blood. And those sensors get stimulated and those receptors say, hey, we need more. So their respiratory cycle is actually stimulated to bring gas in, not blow the bad gas away.
This is the one where if you give them more oxygen, it could be bad for them, right? Hypoxic drive.
Yeah, we'll talk about that too briefly, because as far as the field of emergency medicine goes, if your patient needs oxygen and you give it to them, you're not going to hurt them.
Oh, okay.
That is a legitimate thing, but we spend 10 minutes with these people. That's not going to be enough time to actually physically injure their respiratory drive by giving them oxygen. We could kill them in 10 minutes if they needed oxygen and we didn't give it to them, but we couldn't make them sick by just giving it to them.
All right.
So that hypoxic drive, they are in a chronic state of high carbon dioxide, low oxygen, and their body responds to that dip in oxygen level by stimulating them to take a breath. So that hypoxic drive, it's a pathologic condition, and a lot of the times it will present to us as a patient who chronically has some form of shortness of breath. And they normally call 911 when their chronic problem becomes an acute or emergent problem because their respiratory distress, their shortness of breath has gotten better. I can't tell you the amount of times I've heard, I just can't catch my breath. And your patient sounds like a runaway train while they're breathing. Well, it could be a mechanical problem, but not likely. I don't imagine they went out and got hit in the chest with a bat. It could be a gas exchange problem, sure, depending on what their respiratory condition is. But it could also be these sensors and receptors all throughout their body just being all kind of jazzed up because their blood gases and their oxygen availability and maybe a little bit of increased effort. And I mean a little bit like getting up and walking from one side of their house to the other, or going outside to get the mail, can actually cause a sensation of shortness of breath because their body is constantly hypoxic. So then their respiratory rate cranks up. And if their respiratory rate is starting to go really, really fast, it means they are getting worse because now they need more gas to make this happen, and they're feeling more short of breath and they're having to breathe faster. And we just watch all of that problem start to happen based on the facts that they are chronically hypoxic. And their hypoxic drive is really just another of one of those sort of compensatory mechanisms, because things that they have done in their life have damaged their lungs and damaged these receptors to the point where if they breathed like you and I do and their normal stimulation was, well, when I get too much carbon dioxide, I exhale. And after I exhale, the next logical process is I bring in some good gas. They would stop breathing. All right, we're going to take a short break. It's about 20 after 9. Just breaking this up into usable logical chunks. So we've been at it for almost an hour. Let's take 10 and we'll come back and finish up. All right, folks, we're through the heavy lifting and we're through the A&P and pathophys of the actual respiratory system. Now we're going to talk about some actual respiratory problems. So, emphysema. I'm sure all of you have heard of this before. This is one of the ones that falls under the catch-all of chronic obstructive pulmonary disease. Emphysema is a disease of the alveoli. Emphysema causes a breakdown of the walls of the alveoli. Now, I told you there's 300 million of them in each of our lungs, and the alveoli have a very specific anatomical shape. Alveoli are shaped like bunches of grapes, and they are supposed to be shaped that way, and they are shaped that way for a very specific reason. If I trace around this alveoli and get all the little nooks and crannies, and I'm a terrible artist, but I think you guys get the point. It's going to take me an awfully long time to get all the way around all of this surface area. And the more surface area this alveoli has, the more space there is on it for this gas exchange to actually happen. Whereas my diseased alveoli here on the right side, there's no nooks and crannies, there's no nothing. It looks a lot more like a strawberry than it does a cluster of grapes. And I can trace around this in no time flat, and I have a decreased surface area because of the destruction of all of these walls in here. None of this is available for gas exchange. My surface area has decreased, and if I have a smaller amount of surface area, I have a smaller space for gas exchange to take place. And this is one of our patients who has a chronic problem, who is chronically hypoxic, breathes on hypoxic drive because they retain carbon dioxide, and it is a preventable problem. This is not something that needs to happen to people, because what we'll talk about with some of this stuff is our causes. Emphysema caused by the inhalation of superheated gases that come from the end of a cigarette. Emphysema's root cause, more often than not, is smoking. Those alveolar walls break down, and when they break down, we limit the surface area. And if we don't have as much space for gas exchange to take place, gas exchange doesn't take place, not effectively enough, because we don't have enough room for it all. So they start to retain some carbon dioxide. And when they do that, they switch from hypercarbic drive to hypoxic drive. And they're generally chronically low on oxygen. So one of our vital signs, when we take our pulse oximetry probe and we put it on our patient's finger, that number is going to be low. It's going to be particularly low. And they'll probably be on some home oxygen or have a long-standing history that they can tell you all about. But here's some of what our assessment's going to show us. They're going to generally be thin in nature. So they're kind of like itty-bitty, almost little stick figure-like looking people. But their chest has a barrel-chested appearance. So all of those muscles used to breathe are jacked, but all the whole rest of them looks like it's wasting away. These patients oftentimes will have a cough, and it's cough and cough and cough and cough and cough, but they produce nothing. That non-productive cough is generally dry, and it's just constant and continuous. They'll have a prolonged exhalation period. If they've retained carbon dioxide, why would they have a prolonged expiratory period? Is CO2 good gas or bad gas? It's
Bad gas.
yeah, it's
Trying
bad
to
gas.
keep
It's
carbon
not doing
dioxide.
anything to help us perfuse ourselves. It's not doing anything to help us create energy. So all of that excess CO2, they're actually trying to force some of it out. Some of our patients with emphysema and some of our other medical problems will actually take and make exhalation into an active process. They actually will force their chest wall to get smaller, and they'll contract muscles in the opposite directions to try and squeeze out as much carbon dioxide as they can. And exhalation is supposed to be a passive process. So what do you think what happens when the body tries to compensate by turning exhalation into an active process? What do you think happens with their respiratory distress? When now something that used to be free costs money.
Causes irritation. And
Causes irritation, sure, I'll take it. What else is it likely to cause as far as their respiratory status? Do you think it gets better?
no.
No, they're having to work twice as hard, and they're using muscles that aren't normally used to do something that they're not meant to normally do. And we now have a respiratory status that has gotten to the point where it is work on both sides of the equation. They are just flying through available energy. And if we talk about muscles here for a second, if those muscles aren't normally used to accomplishing that work, do you think they probably get tired faster?
Yes.
Yeah.
Okay. And in getting tired faster, do you think they start to demand more oxygen?
Yeah.
And if they're demanding more oxygen and they're getting tired faster, this respiratory problem is now growing exponentially every single time we look at this patient. And this is realistically the way that a lot of these things go. Respiratory rate speeds up. We see the use of those accessory muscles. Those accessory muscles are the ones that aren't normally used to actually doing the work of breathing. We'll see a patient who has retractions here above their clavicles, or we'll see retractions in their rib cage when they're inhaling and when they're exhaling. We'll actually get to physically watch those muscles work their behinds off to try and actually make the work of breathing a little bit easier and a little bit more effective. We'll see our patient using muscles in their neck or flaring out their nostrils, trying to bring in as much oxygen as humanly possible. And all it's doing is, yes, compensating, sure. But that compensation, that phase is only going to last a short period of time. Soon enough, oxygen demand and oxygen delivery are an equal problem. And we go from respiratory distress, a patient who is just having trouble breathing, to respiratory failure in a patient who now their need to use energy to make this process happen is outweighing the amount of energy that it's actually creating. And one of the things we'll see with a patient who's getting close to respiratory failure is someone who the effort of breathing is so high that they almost start to fall asleep between breaths, or they start to have an altered level of consciousness. Most of the time, our respiratory patient who's in respiratory distress, since it's called distress, it's distressing, and they are panicking and freaking out and trying to just do whatever they can to make this gas exchange happen. And as they get sicker, they get to that apathetic point. They get to the point where their body is no longer creating enough for itself, and they start to nod off and fall asleep right there in front of you. We'll see their respiratory rate get to the apex and eventually start working its way back down. And once we see things like that, we have officially gotten to the point of respiratory failure. And realistically, we probably should have started ventilating that patient conscious and alert anyway, a few minutes before that. to try and decrease some of that workload and increase the amount of gas that they have available. And you will honestly, when you start to see a patient who is having so much trouble breathing that they'll be conscious alert and speaking to you, and you'll be ventilating this patient and coaching them through just letting you breathe for them, because their body is getting ready to give up doing it altogether. We do get to a point in all of this that just assisting them and giving them increased oxygen availability is no longer going to support them as a human. Chronic bronchitis is another of our chronic obstructive pulmonary diseases. This is a lot like the bronchitis you'll get when you have, a chest cold and they prescribe you a Z-Pak and you get better in a couple of days. The only problem with this bronchitis is all of those mucus plugs and all of that inflammation and all of that crud that's hanging out down in those alveoli never goes anywhere. They'll cough and cough and cough, and they'll get rid of all that mucus, and it just comes right back. It never really goes away. And all of that irritation and all of those mucus plugs and all of that coughing will cause inflammation in our alveoli, and it will make that one cell wall thickness that we've talked about thicker with all that inflammation. So now we have plenty of oxygen, we still have plenty of space, but instead of just having to go through that one cell wall and diffuse into the bloodstream, it has to go through one cell wall and all of this inflammation and all of that swelling, and the gas can't exchange itself quite as easily. The airways get more narrow, and these mucus plugs can actually close off entire portions of our patient's lung. It's an inflammatory process. It's caused by smoking. We have thickening of those walls that make it more difficult for the gas to move one way or the other. On top of that thickening, we also have that excess mucus, so the gas needs to move through a thicker wall out into the bloodstream, but it also has to go through pudding at the same time. And it just makes the process of getting gas to go past each other and getting that high concentration of oxygen out of the alveoli and getting that high concentration of CO2 out of the blood to just go past one another so they can get to where they're supposed to be. Our chronic bronchitis patient differs from our emphysema patient in this right here. We've talked about cyanosis. We've gone over, the bluing of the skin, and we have bluing of the skin on the gums and the lips and in the nail beds. And sometimes our COPD patients, our chronic bronchitis patients, will chronically be that color. They will always, around their mouth and in their fingernail beds, actually have a bit of a bluing of the skin because they're chronically hypoxic and they chronically have hypoxemia and hypoxia, and it never gets any better. When we start to get concerned about a patient who is chronically cyanotic and chronically hypoxic is when it changes. When that bluing starts to now move from just the nail beds and starts to creep up their hand and up their arm, or instead of just around the lips and gums, we see bluing of the entire face. We know that this patient's perfusion status is beginning to get worse and worse. Our patient presentation for these folks is they are typically overweight and they are chronically complaining of difficulty in breathing and can be chronically cyanotic. Why do you think these people would be typically overweight?
Wait, you asked why people are typically overweight?
I'm asking why these people specifically would be typically overweight. Why would your chronic bronchitis patient probably be a bit on the hefty side?
Because exercising is really hard for them.
Exercising would be hard because they won't be able to breathe, so they would have to continuously take breaks if they did exercise.
And it's more than hard. Exercising would actually just be out of the question. Exercising is not even a thing because breathing is so much work. And just getting gas moved from the outside to the inside is so much effort that walking across the house sometimes is too much work. They'll spend a good deal of time either on the couch or in the bed just breathing. There's so much effort involved in that alone that just staying alive makes it so that they can't actually get up and move around a whole bunch. Their cough, generally productive, will hear what they call coarse rhonchi. When we listen to their chest, it'll sound like that sort of like gross sound you hear if you had something like bronchitis or pneumonia, you know, that rumble just sort of sounds like there's sludge in their lungs. We may hear some wheezes, we may hear some crackles, but if you're thinking chronic bronchitis versus emphysema, generally your chronic bronchitis patient is going to sound like they have a whole bunch of crud in their lungs. Your emphysema patient is going to be more of a dry sort of wheezing sound. So you guys tell me, what do you think the treatment for these problems are? What are we going to do for them?
Give them oxygen.
And that's pretty much it. These patients are COPD patients, chronic bronchitis, emphysema. They're going to get oxygen. We're going to titrate it to effect, just like protocol says. We're going to try to achieve a pulse oximetry of 94%. All of that, sure, that's great. But really, we're going to assess our patient. If my patient tells me they're short of breath, and my machine tells me that their pulse oximetry reading is whatever it says, I'm going to listen to my patient and I'm going to treat them accordingly and treat them appropriately. Because at the end of the day, the patient is the one that I'm there to treat and take care of, not the machine. Don't always hang your hat on having pulse oximetry available to you and, oh, well, I can't give them any extra oxygen because their level is this or their level is that. Because what I'll tell you about pulse oximetry is it is one of the most ineffective pieces of equipment I will show you. If your patient is cold, it doesn't work right. If your patient is hot, it doesn't work right. If your patient is wearing a specific color of nail polish, it doesn't work right. If your patient is hypovolemic, it doesn't work right. If your patient is full of carbon monoxide and dead on the floor, it will give you a pulse oximetry reading of 100%. So assess your patient and treat what they're telling you. Don't always rely on the fancy equipment because sometimes the fancy equipment lies. So we're almost there, folks. We're almost there. Next, we have asthma. So I know a couple people out there said they had asthma, right? Or know somebody who did.
Yeah,
So
I do.
asthma is a disease of constriction. The lower parts of our airway are going to get all shrunken down. We have this smooth muscle that surrounds all of our bronchioles, and it controls how big they get and how small they get. A lot like our vascular system. That smooth muscle does the exact same thing. It can expand the size of our bronchioles if we need it. It can constrict the size of our bronchioles if we need it. And with asthma, it's called bronchospasm. Those respiratory bronchioles and all of the lower structures of our airway, that smooth muscle actually spasms and clamps everything down. Asthma patients oftentimes will complain of a tightness in their chest. Our asthma patients a lot of times will feel like they can't get any out. Asthma is oftentimes a disease of I can't get gas out. We have all of these things going on. We have that bronchospasm taking place on top of now being constricted and shrunken way down. more mucus is produced. So now we have a smaller spot that's filled with sludge and all that mucus is down there. Those mucus actually might form plugs and completely block off the alveoli. And our patient has this just ungodly tight feeling in their chest. And when we listen to their chest with our stethoscope, we're going to hear wheezes most of the time on exhalation. Sometimes, depending on how sick they are, we may hear wheezes on inhalation as well. Sometimes we might not even need a stethoscope if they're really that sick to actually hear that wheezing noise as they're moving gas back and forth. And every bit of it is a result of this bronchospasm, the swelling, the mucus, all of that in the lower airways. This is a reversible process. We have a medicine that fixes this. So on top of getting oxygen, what are we going to give to our asthma patients?
Albuterol.
Albuterol, absolutely. Albuterol is what's called a beta agonist medication. It acts on those smooth muscles and it gets them to relax. And if we get those smooth muscles to relax, we get rid of all that bronchospasm, we open up their airways, and they no longer will have this telltale sign of chest tightness. The wheezing will actually begin to improve. Maybe they're still complaining of some difficulty breathing. Maybe they're still coughing, because remember, all of this is still going on. Maybe they're still breathing fast, trying to get their oxygen levels back up and trying to really get some reserve built up and starting to feel better. They'll be tachycardic. Why do you think they might be anxious? Why do you think our respiratory patient in the very beginning stages is generally very anxious?
Because they don't understand why they're experiencing chest tightness and they can't get it under control.
So what was that last part you tailed off?
I said they can't get it under control.
Yeah, it's not even necessarily that they don't know why it's happening, but they can't fix it. They can't get it under control. It's anxiety driven, right? They have all of this going on and they are having just a terrible, awful, horrible, no good, very bad time trying to breathe. And they are scared witless. We can fix this. Generally speaking, when somebody who has asthma has the first signs of an asthma attack, what do?
Hyperventilate.
Go for their,
Hyperventilate. And then what?
go for that albuterol if they have it.
Yeah, they reach for that albuterol inhaler if they have it, and they push the medication 55 times, trying to take these tiny, short little breaths and get it down to where it goes. Now, that albuterol acts on the smooth muscle in the very, very bottom, very, very lowermost portions of your patient's airway. So if your patient is having such a difficult time breathing and using their albuterol inhaler, that medication is not going to get down there and work. If we show up and they have not already used the maximum dose of their metered dose inhaler, we're going to talk them through it. We're going to walk them through the steps of using that medication appropriately. We're going to have them take their inhaler and purse their lips and put it right there. And we want them to exhale as much as they can. We want them to blow out as much as they can. And then as they're inhaling, we're going to have them squeeze the medicine canister and introduce that medicine into them and take as deep a breath as they physically can get down. And then we're going to tell them to hold their breath, because we need that medicine to get down as deeply as it can and stay there for as long as it can to actually reverse that bronchospasm. Now, all of this is, first of all, difficult for them to accomplish because they're having a hard time breathing. Then we're going to take a patient who's having a hard time breathing and tell them to hold their breath. Albuterol in a metered dose inhaler, as your patient progresses and gets sicker, is generally not super effective in an inhaler form. But we also,
Will we have an air chamber for them to use with the actual Pro Air, or if they don't have it? Because I know that makes it a lot easier to inhale the
Yeah.
meds.
they're supposed to get a spacer with their prescription, and it's just a plexiglass tube that actually makes it easier to breathe that medicine in. Most
But
of the
say
time,
they don't have it.
well, if they don't have it, we still have a solution. If they don't have it, we're going to offer them a beta agonist medicine, just like the one that they take, and we're going to ask them if they would like us to give them albuterol in nebulized form. Now, on your protocol sheet, you'll see there's a whole like flow chart and a bunch of check boxes and stuff, and we'll go over that in lab. But realistically, it's, I have a medicine that works just like your albuterol. Would you like me to help you with it? And of course, since they're having difficulty breathing and really probably didn't wake up with the intent to go into respiratory arrest and die that morning, they'll probably want you to help them with some albuterol. So we're going to put 2.5 to 3 milliliters, one albuterol bullet into this nebulizer chamber. We're going to put it all back together, and we're going to put this handy dandy either mask on their face or some little peace pipe looking thing in their hand, and tell them to just breathe normally, but breathe as deeply as they can. And in just breathing in this nebulized albuterol, and especially with the mask, having it be right on their face and staying there as they're breathing it, it gets all the way down to those spasmed bronchioles and opens everything up just like magic. Until it doesn't. Because since asthma patients are typically very, very familiar with their condition, a lot of the times they wait until the exact last minute to call 911 because they think, oh, it'll get better, it'll get better, it'll get better. And then it doesn't get better. And we wind up with a patient who now is even further down the road, and albuterol is not going to help them. We have a fix for that as well. If our patient who is prescribed albuterol has maximized their dose, and we have given them our nebulized albuterol, and they still don't get better, what's something else we could do?
Would it be
Anybody?
to give them aspirin?
No, it is another medication that we carry, though.
Would it be epinephrine?
It would be epinephrine, because epinephrine acts on those spasmed bronchioles as well. And we can actually give them an EpiPen autoinjector to relax that smooth muscle that's around those bronchioles and open everything right back up. And our patient will actually improve every bit as fast. But epinephrine is like our last line of defense at that point. So it's not going to be epi in the nebulizer. It's going to be an EpiPen. And it will work the exact same way as it does with our patient who is in anaphylaxis. It goes in, it's going to speed things up, it's going to make their heartbeat faster, it's going to make their heartbeat stronger, it's going to make their respiratory rate faster, but it has the opposite effect on their respiratory system. It actually gets down to those smooth muscles and pops everything back open, so that now my patient can actually move gas in and out and is no longer having such a difficult time actually getting gas down to those alveoli and getting gas out of those alveoli. And epi, really, especially if we're that deep into it with a patient, is probably going to be what stops them from going into respiratory failure and respiratory arrest. Because if you have maxed out your albuterol, you can't do anything else, and you are now at the point where you are sticking this patient with an IM injection, we are way in the weeds. This is a sick person right in front of you. And epi will, for sure, be one of the things that pulls them out of being such a sick patient. All right, coming up next, we're going to do Chapter 17, Neurologic Emergencies.